Thank you very much. And I'm almost convinced after listening to Dr. Raki that I should actually give up liver transplantation and focus more on plasma exchange. But anyway, my first thing is that my interest in transplantation actually began from this institution. In 1990, Professor Biliary conducted the global plenum on transplantation. That's how I got swayed into transplantation. So my talk would cover some background, a little bit differences from that have not been highlighted in the definitions and how we transplant surgeons look at ACLF. A lot of DDLT experience that has been published, but very little LDLT experience has been published, and results of our center for liver transplant for ACLF at the time of going to transplantation. There's a lot of data on ACLF3, which has reversed and then gone on to have successful transplantation, but there's hardly any data on patients who are in ACLF3 at the time of going for transplantation. So to start with, in the beginning, there was a sort of nihilistic approach to ACLF, and they would sometimes be denied ICU care till Nizeman showed that you could have a sort of at least a 60% 3 months survival, even ACLF. So clearly, these patients should not be denied ICU admission. But at the same time, these sick patients who are admitted in the ICU are rarely considered for transplantation. And this showed this paper from Journal of Hepatology 2017, only 2.9% of admitted cirrhotic patients in a French ICU actually underwent transplantation. And living donor liver transplant are even less likely to be considered while admitted in the ICU with organ failure. However, with the Bell score introduction, there was a sort of a lot of sick patients started getting transplanted, and therefore an interest emerged in these sick patients. I'll just briefly define ACLF as has been defined by the Parcel group and has been defined elsewhere. The Parcel group, obviously, with the fact that is the first presentation and is a liver insult, not a infection insult, and not an organ failure approach. Therefore, it's potentially reversible, and that's the way it should be treated. But how we look at it is we see patients with cirrhosis and with established organ failure, and therefore these are patients who are unlikely to be reversed by medical therapy, and these patients should be fast-tracked for transplantation. So I've already said this, that in the Parcel group, there's a strong possibility of reversibility because it's the first presentation and it's not really an organ failure kind of approach. And if you have the ARC score, the problem with the ARC score that we clinicians have who do transplants regularly is that very few of us see patients who have a creatinine less than 0.7 or less than 1.5. Most of our transplant patients with ACLF will have a creatinine greater than 2. So we've chosen to look at the Cliff-Scoper score as a way of looking at outcomes in these sick patients. So if you look at the ARC score, obviously those who are grade 1 to grade 3, and then the mortality correspondingly increases as the grade worsens, and grade 1 has potential recoverability, grade 2 requires special monitoring, and grade 3 requires immediate intervention. But on the other hand, if you look at the Cliff-Scoper score, which looks at in a sort of a more realistic manner with renal function particularly, that you have to have a creatinine greater than 2, which is quite often either less than 2 or more often that you have greater than 2. Most of these sick patients have it. So these patients, as the organ failure increases, these patients will die. Have been shown sort of in one paper after another that these patients would die without if they have more than 3 organ failures. But the transplant community very reluctant to do liver transplant in these patients because the first publication was in 2011, 13 patients with ACLF3 and sort of a survival only, or 90-day and 1-year survival of 62% and 46%, which was much lower than the classically accepted threshold. Then we come to 2017, where 73 patients with ACLF3 were transplanted, and the 1-year survival was 83.6%. The interesting thing was that every single patient in this group had a complication. So obviously, start with the complication, expect to have complications post-transplant. And then Tulabat also showed similarly that if you have multiple organ failure, still transplant, more than 70% survival at 1 year was possible. The important thing that was learned from the DDLT experience was that in ACLF, it's not the smell sodium that is important, it's the organ failure that impacted on the outcome. And therefore, people who had a MEL score less than 25 actually but had organ failure did worse than those who had higher MELs, possibly from sort of physiological differences and greater incidence of infectious complications and organ failure. So ACLF3 without transplant has high mortality. That is, I'm talking about ACLF3, which is really something not highlighted so much in the literature. There are a lot of reports on patients with ACLF3 then who sort of reversed and then went on to have transplantation with good results, but at the time of transplants. So these patients many of them, only 10 out of 111 survived without transplantation, but those who survived had a good over 80% 5-year survival. So what about living donor liver transplantation for ACLF? It's a different story altogether, smaller graft, myriad technical complications, and takes a long time to complete. And although it may seem that there is an endless supply of healthy donors, in fact, it's not so. The blood group incompatibilities, sort of fatty livers, and sort of legal sort of clearances for transplant. And one of the worries that we transplant surgeons have, that you may sort of take up a patient and he collapses during the operations. You have a orphan graft, you don't know what to do with it. And therefore, living donor liver transplant for ACLF is still in its infancy. So I'll look at some data that has been published on living donor liver transplantation for ACLF. The first report was from Taiwan, 2003, where the Basel definition was used and infection was treated preoperatively with excellent outcomes, like that of a normal cirrhotic patient. Avison's group reported excellent outcomes after living donor liver transplantation for ACLF3. But if you look at the paper, none of the patients at the time of transplant had circulatory, respiratory, or renal failure. And in fact, the only true realistic picture you get is from S.G. Lee's paper from Masan, who reported a 5-year graft survival in ACLF group as 70% versus 81%. So this group did worse than the other groups. And that's a center well known for excellent outcomes after living donor liver transplantation. And 2021, the same group which published in 2013 showed excellent survival in patients with and without ACLF. In fact, the non-ACLF group had a slightly lower survival at 5 years because many of them had HCC. So I've already talked about this, that 2013 paper, these were patients, mostly hepatitis B, infection was treated and excellent outcomes. I would like to spend a little bit more time on the S.G. Lee publication in 2017. So this is a center which has done phenomenal work in living donor liver transplantation. In fact, in 2019, I think, they reported 0 mortality after living donor liver transplantation. And in their ACLF group, that 1, 3, and 5 years, the survival was only about 5-year survival was only 70% compared to the non-ACLF group. And they suggested that patients with high MEL score should be transplanted before they develop ACLF. They suggested that if they have a value more than 25, they should be transplanted before they develop ACLF. And this obviously suggested a higher graft volume, and they noticed higher arterial complications and re-exploration rates, which is similar to what I'm going to present later on. So 2018, Avison's group paper reported excellent survival after transplant for ACLF, but the interesting thing was that none of the patients had renal, respiratory, circulatory failure at the time of transplantation. So we do not know how many patients actually who presented with ACLF and could not be transplanted. And alcohol and infection were the common precipitating factors. In the Kaohsiung group, in contrast to what they published earlier, they said that they treated infection aggressively, but in the latest study, they had 112 patients, and in which they said that the preoperative infection resulted in more post-operative infection, which is obviously logical, but it did not result in this mistake, it did not result in higher mortality. And this just suggested some improvement in techniques. such as recipient approach first, early portocaval shunt, implantation with side clamping, relocal laparotomy for septic collection, and a delayed Roux-en-Y hepatic oxygenostomy. Some critical steps in anesthesia, these patients are very susceptible to volume overload. So use of concentrates rather than products, slight volume deficit, maintain preoperative sodium levels, whatever that may be. So try and stick to it in the first 48 hours, avoid intraoperative CRRT. And this we published in Clinical Transplantation 2021 with good results. And once your liver's in, you go for volume expansion and diuretics. These are patients who have multiple infiltrates and sometimes impossible to know whether they're infective or whether they're just a part of the liver disease and fluid overload. And these patients would therefore post-transplant require good analgesia. And we've actually used NSAIDs in the first few days because nothing gives better pain relief than NSAIDs. Use of fentanyl results in respiratory depression. And we followed the policy of bottoms-up immunosuppression, which is as they get better, we keep stepping up the immunosuppressive dose. So what do you do with renal dysfunction? And assessment of recovery renal is very, very difficult. So we were one of the first groups to actually start promoting sequential transplants rather than combined transplant, because these sick patients at the end of the liver transplant operation are hypotensive, acidotic, they've lost a lot of blood, the inotropes, and certainly not the milieu for a kidney transplantation. And this practice, I find, has now been incorporated elsewhere, and even in UNOS, there's a safety net. First, you do a liver operation, and if the kidney doesn't recover, then in the first year post-transplant, you have access to a kidney on a priority basis. Living donor liver transplantation may actually preserve and restore renal function. CRRT till the patient is not ambulatory, but after that, you need to change to SLED because otherwise they're bedbound. Liver biopsies, very little role in these sick patients because more often than not, it's just sepsis. And one of the problems that we face all the time is whether it's rejection, infection, but now it's quite clear that these sick patients actually do not reject. They may have cholestasis, but that doesn't necessarily mean rejection. So a bottom-up policy that where you keep increasing the dose as they start improving. And particularly in ABO-compatible living donor liver transplantation, there should never be a tearing hurry to treat rejection. But as the patient gets better, you will be able to treat rejection, even if you do delayed treatment. Some of these will require repeat laparotomy, has been shown by the Kaushan group in their later paper, not the first one. And sometimes it's very helpful. You can have liver biopsy, bile leaks and obstructions can be ruled out, peritoneal lavage, portal pressure measurements, thrombectomy, neo-MHV, and splenic artery ligation. One of the problems that we've identified in dealing with these sick patients is that they've been on the ventilator, and somewhere along the line, they've been sort of on inotropes, and they've actually had hypoxic damage while intubated. So this is a very key thing that needs to be ruled out before you take up these patients for transplantation. If they have preoperative HE, they may have difficulty in extubations, early tracheostomy, and use of NSAIDs for the first few days will not affect the renal function, but very important to get them breathing on their own. Chest infiltrates we talked about. And finally, when not to transplant is septic patients. Obviously, their blood pressure cannot be maintained, the airway cannot be maintained, the oxygenation cannot be maintained, or they have an infection from an organism from which they've recovered and again fallen ill from that infection, then we would not consider them for transplantation. Finally, coming to the end of what we of my talk, which is to share data with you of patients who underwent transplantation for ACLF3. And so we had a total of 430 patients with ACLF, and predominantly males, and deaths without transplant 207. The average MEL score was 35, and average hospital stay prior to demise was 6.6 days. And 66 patients, we lost them because they went LAMA because probably they didn't like our suggestion of transplantation. So liver transplantation for ACLF were 157 patients. The average age was very young patients, most of them are. And ACLF3 out of this was 64. And overall, we had a 42%, 27% mortality out of this 64 patients. So ACLF 3 does very poorly after transplantation. Many of them had sort of re-exploration for bleeding, arterial thrombosis, portal vein thrombosis, bile leaks, very, very sick group to transplant, required renal support, neurological complications, and average length of stay was 33 days post-transplant. And majority of the indications were ethanol. But if you look at in a sort of the complete picture, then you find that the non-ACLF did obviously very well. ACLF1 also did well. ACLF2 also did reasonably well. But when you come to ACLF3, you have 42% mortality post-transplantation. So in ACLF, data on plasmapheresis focuses on short-term survival, while data for liver transplantation looks at long-term survival. So I would suggest that we should keep our perspective while looking at data for sort of alternative therapies for ACLF3. In patients with lower MEL, plasma exchange may offer survival advantage provided liver transplantation can be carried out timely. And patients with MEL more than 30, plasma exchange mainly acts as a bridge, and these patients should have transplant. Of course, these patients will have higher morbidity and mortality, particularly in the Indian setting. And the advocates of plasma exchange should not base their case on non-availability of liver transplant expertise, because we have been transplanting now for over 30 years in this country. Thank you very much for your attention.